As Angus mentioned, I'm Andrew, and I'm a first-year medical student at UBC. And so I work with this group, Universities Allied for Essential Medicines, which is an international student group with chapters at research universities all over the place. And basically what our group does is advocate for universities to do things exactly like what UBC is now doing. So I'll start off by just talking a little bit about why we ask for that. So this is Joseph. He's an HIV-positive man from South Africa. And in 2001, Joseph had late-stage AIDS. He was basically on the verge of death. And he wasn't alone. The HIV prevalence in South Africa at that time was 1 in 4 adults. And it hasn't changed. It's gone up since then. In Canada, we'd been providing free universal HIV treatment since about 1996. But since the drugs were patented, the price was over $10,000 per patient per year for a course of treatment. So just manageable in Canada, but far beyond the means of almost everybody in South Africa. So almost nobody was receiving treatment, and this was the norm throughout the developing world. So in that year, in 2001, Doctors Without Borders, or Médecins Sans Frontières, wanted to change this. They decided that they wanted to open the first free HIV clinic in sub-Saharan Africa, in South Africa. And in order to treat more than just a handful of people, they decided to see what they could do about reducing that price. And one HIV drug that they wanted to use was this one over here on the left, which is called D4T, or stavudine, which had been discovered at Yale University. So MSF approached Yale to request that this patented drug be made available off-patent in the developing world. So they wanted a generic company to produce this drug, and they thought that that could be done for a tiny fraction of the price that was currently being charged. But unfortunately, Yale had licensed the exclusive rights to a pharmaceutical company called Bristol Myers Squibb, and Yale said, there's legally nothing we can do. It's out of our hands. So there was a really nasty PR campaign after this occurred. MSF took out a front page ad in the New York Times. There was a lot of student activism going on at Yale over this issue. And eventually Yale and Bristol Myers Squibb got together and discussed this and decided that, okay, they started by agreeing to lower the price. So this $10,000 per year drug, they immediately cut the price by 94% down to $600. And just a short time later, they agreed that, okay, generic companies can actually produce this for the developing world, and those companies were able to bring the price down to $350 for a course of treatment. So a really, really dramatic drop. So MSF, thanks to this price reduction, was able to open its clinic in South Africa. And people like Joseph here were given a new lease on life. So this is Joseph, just a little while later with his little girl. He's been restored to basically full health by access to antiretrovirals. This was the first major concession on an HIV drug, and it paved the way for treatment of millions of people in the developing world, which a feat that was considered completely impossible just 10 years ago. So this is the number of people on treatment in low and middle income countries throughout the world. The dark blue part on the bottom is sub-Saharan Africa, and you can see the dramatic growth in treatment since the time of these first concessions. So, but of course this issue is not important just for AIDS. It's a general problem. There's lots, despite all the incredible discoveries that medical research has made over the past century, there's still a lot of people that fail to gain access to the innovations in treatment that we've made. The number of people actually that die every year for lack of access to treatments that already exist, according to the World Health Organization estimates, is still at least 10 million people. So, and it's not just infectious diseases either. To take one example, 80% of mortality from cardiovascular disease actually occurs in developing countries, and lack of access to drugs, which are a mainstay of treatment in the developed world, are a significant component of that. So, of course, cost of treatment is by no means the only barrier to access, but it's certainly an important one, and one I think is worth removing if we can. So back at Yale, students who had been involved in this campaign learned that the problem is one where universities have an important role to play. as public research institutions and recipients of public funding. So, but they thought that rather than trying to fight an ugly PR battle for every drug that comes down the pipeline and trying to fix things after the fact, they decided that they proposed a proactive solution. So universities, they said, should include access provisions in their licenses right from the start. And so our organization was born. And today we've got chapters of our group at about 35 different universities in Canada and the US, including one in the UK and one just starting up in Australia. And that includes us over there on the West Coast. So that's us. And so students at UBC got on board with this project a couple years ago and started doing some research, trying to learn their way around a seemingly arcane world of patents and licensing and stuff that I hadn't really anticipated becoming interested in, but considering the importance of the issue, I actually started finding it really interesting. So yeah, we started doing our research. We started making some friends in high places. You probably recognize a few of these people. And in February last year, we eventually managed to get a meeting with these people. So that's President Toop, Vice President John Hepburn, Angus here, and Barbara Campbell as well from the UILO. So we presented our ideas to them, saying they were already doing basically global access for Brett Finley's project at Gates' request, and we said, well, why not do this, not just for this one project, but for every opportunity that comes up, whenever it's possible. And to our delight, they basically took us up on it. And 2 months later, they had a draft strategy to present to us. They posted it on their website shortly after that. We started hearing examples about new technologies being licensed in this way as early as that summer. And this was almost unprecedented for UAEM. UBC is the first university in Canada to do anything like this, and only 2 schools in the US are doing anything similar. UC Berkeley and the University of Washington have taken steps in this direction, although I'm not sure if they're as comprehensive as what UBC has done. And the news got out. So a few local papers wrote articles about this new approach, including some student papers elsewhere in the country. I'll point out that ours is the bottom article. That top one is. We're not involved in the top article at all, so don't worry. But of course, this isn't just about getting our names in the paper. It's about trying to provide everybody with the same quality of life that we enjoy here in Canada, trying to break the cycle of poverty and give everybody the chance to live a life of dignity. And while affordable medical treatment is by no means a complete solution to that, it's definitely an important piece. And importantly, it's something that universities in particular are well placed to have an impact on. I mentioned I'm a medical student, and when I'm a doctor, in my ideal world, I would like to be able to provide the same standard of care to everybody, no matter where they live, whether I'm caring for patients in Vancouver here at VGH or anywhere else in the world. So I'm really encouraged to see UBC show real leadership on this issue, and I sincerely hope that other institutions now will take up this challenge as well, to ensure that the benefits of the kind of important research that we've seen tonight will reach as many people as possible, and that the treatments of the future will not be unnecessarily denied, and to hopefully bring us one step closer to that ideal world. Thanks.